I have 3 objectives today. One is to go over some definitions, scope of the problem, not just of opiate use disorder, but of substance use disorders in general, both nationally and locally. And then to talk about the role of the primary care physician or the first point of contact physician, and the different roles we can play in different contexts. And then also discuss the harm reduction model, which is what we're using many times when patients are not ready for change or don't want like ideal care. They want care that fits their life a little better. And here we go. So first, the scope of the problem. So it used to be that we kind of thought of people as having substance dependence. So that's physiologic dependence, things like needing more of the substance to get the same response, withdrawal symptoms, cravings, and then people who have abuse or consequences of substance use. And these were sort of thought to be kind of 2 separate pieces, but the reality is it's more of a spectrum. There's very few people who have pure substance dependence and very few people who are purely abusing substances. So these are the different DSM criteria. I still have them broken down that way, but we don't really care how many you have in which category or anything like that. What we care is how many of them you have. So you can have a substance use disorder that's defined as mild, moderate, or severe, depending on the number of points that you kind of hit for substance use disorder. We try to avoid using stigmatizing language, talking about people who are addicts or alcoholics. Some of these words have like social stigma to them. So we really try to use the word substance use disorder as our umbrella term. And then we can talk about specific substances like alcohol use disorder, opiate use disorder, tobacco use disorder, et cetera. So this data is from 2017, so a little old, but COVID kind of affected our ability to effectively survey people. So we don't have tons of stuff from the last few years, but I think this is a really important pie chart. So this is a cross-section from the United States, and of everyone surveyed, which is ages 12 and up, 7.4% of people met the criteria for a substance use disorder at some point in the last year, which is huge. That's people 12 and up. So that's like 6th graders and up. So hopefully the 6th and 7th graders aren't a huge piece of that pie, and it's mostly adults. And if you think about that number in a primary care clinic, you probably have 10 to 12 patients per session. So 1 to 2 people is going to probably have a substance use disorder, whether you identify it or not. The vast majority of substance use disorders are going to be alcohol use disorder. So 14.8 million Americans met criteria for alcohol use disorder in a given year. And then illicit drugs also make up a big chunk. And when we say illicit drugs, that includes marijuana, since on a federal level, it is considered an illicit substance. And yeah, that's all I'm going to say about that one. So the best source for national data is going to be this survey called the National Survey of Drug Use and Health, or NSDUH, and that's really what they call it. So the NSDUH survey they do mailers, but they also send people out into the field to really try to get out into communities and learn about both substance use in communities as well as mental health problems in the community. So they ask about substance use, but they also ask about like depression, suicidality, and things to really get an idea of what's going on the national level. And the surveys that they do, they also break them down by state, so that information is available easily online. And these were just some salient points from the 2021 data, which is not officially published yet, but some things I thought were really important. Of the 9.2 million Americans who misused opiates, so not necessarily have an opiate use disorder, but misused opiates, so, you know, kept some left over from their gallbladder removal and then used it for something else, gave it to a friend, borrowed grandma's, whatever. 8.7 million of those 9.2 were misusing prescription opiates. So whether they were given to them or given to somebody else that they then acquired. And 1.1 were using heroin or other more non-prescription opiates. Now, when you look at who is suffering from substance use disorders, really young adults are kind of the biggest population to think about. Well, not the biggest in terms of numbers of people, but in the group of 18 to 25-year-olds, about a quarter of people met criteria for a substance use disorder in a year. And if you think about, culture around alcohol in our country amongst young adults, you can see how that could happen. I think also because we're in healthcare, we tend to be surrounded by people who are making healthier life decisions. Like, I can barely count the number of people I know personally who smoke heavily or anything like that. But in the United States, things like smoking and heavy alcohol use have much higher prevalence than maybe they do in our personal cohort. So something to keep in mind. So a quarter of people 18 to 25 met this diagnosis of substance use disorder, and then 16% of adults 26 and older, which I think is a really unfairly large group of people to put them all together. But so that's 35.5 million Americans. And then another important thing is that of people who have an alcohol use disorder, over 96% of them did not feel they had a problem that needed help. And I think that just speaks to the normalization of the way people are using alcohol inappropriately in our country. All right, so I know a lot about the Maryland data. I tried to find more DC data. The Department of Public Health, or the health department's website, was a little hard for me to navigate. So I'm going to share some Maryland numbers, which I think translate to a fair number of your patient population. So Maryland has an incredibly high opiate overdose rate. It's 32.2 per 100,000 people. The national average is 14.6 per 100,000 people. So we're over double the national average for opiate overdoses per capita. I like to show this graph because it shows what people are overdosing on. The line that really stands out is going to be the green line. If you couldn't guess, that's the line for fentanyl. It really starts to peak around 2015 and has been steadily climbing. Fentanyl, honestly, I think most people who are using fentanyl are aware that they're using fentanyl. It's what's available to them. It's way less expensive than trying to get pure heroin or getting pills from people. And so people are either knowingly taking something that has some fentanyl in it or knowingly taking pure fentanyl. But it is causing a lot more overdoses, and presumably the vast majority of these are accidental. The next line I want to draw your attention to is the dark blue line, which also starts to go up around 2015. That's actually cocaine. So cocaine use disorder is a much bigger problem and a trending problem that I think we're kind of all having a bit of a blind spot for. I think we think of it as this drug that was like from Wolf on Wall Street in the 80s or something, but it actually is having heavy use amongst manual laborers, people who need to just like stay awake and not feel pain for their work or whatever. And so the rate of cocaine use is actually on the rise as well. And what we found in Maryland anyway is that over 40% of fatal overdoses were people with combined opiates and cocaine, so in their system. So the combination of the two is also very common. People get really excited about like new trends on the street and new drugs that are out there and what's the next thing. There was like that crocodile many years ago and all this stuff. So it is an evolving black market at all times. People are always trying to find ways to adulterate the substances that they're making and selling to people so that they have a longer high, a stronger high, or just are cheaper to produce. So there are some grassroots organizations that try to keep track of these trends so that, if there is an upcoming trend, we're aware of it. The current thing that people are really talking about, especially in the mid-Atlantic, is xylazine. So xylazine is a tranquilizer used in the veterinary community, and it comes in pills, powder, and liquid. And people are cutting fentanyl with it specifically because fentanyl has such a short half-life. If you add this to it, it makes it last like up to 8 hours in your system. So the problem is if you are given fentanyl with xylazine and you don't know that, you might sort of like stack your doses of fentanyl in your body just based on your past use patterns, and then accidentally overdose more easily. Also, people are finding that they are getting really gnarly skin wounds that are not healing very well when they have xylazine mixed with their fentanyl. So yeah, I think the big things to remember from that part are that the NSDA survey, which is the national survey, is a great source of national data, but you can also pull out your own state or DC data from that. I found looking at DC kind of hard because all of the suburbs of DC are kind of wrapped into all the different states. And so it was kind of hard to parse out for you guys specifically, but it is all there. And then you can go to your local health department website. Most have a subset that's specifically for opiates, talking about trends in your state. So now on to our role as the primary care provider. So I acknowledge that not everyone who goes into primary care ends up having this huge passion for addiction medicine and may feel a little nervous about taking this on as part of their practice. But there are certainly things that everyone in primary care should be doing to help address substance use disorders. And then there's the things that maybe people who are a little more excited about it or want to take on more of the medical part of it can consider doing. And I'm going to share those things with you. So the thing that everyone should be doing is screening, diagnosing, and educating their patients. I think that's a pretty easy piece. We're going to go into it because it's not always the easiest, but that's probably the part that everyone in primary care should be doing. Initial management and stabilization of patients, so helping patients detox, getting them onto maintenance medications. It's kind of a high needs time for patients, but especially if they're hospitalized, it's a really great opportunity. And then in the outpatient setting, if you do have the support staff, like maybe if you have social work in the office or you have the flexibility in your schedule to really follow somebody closely, it's great if we can do this for people. And then maintenance management for different substance use disorders, I think is also easy to wrap into primary care. The other big role we have is as physicians in general, not just in primary care. So no matter what subspecialty you go in, or if you become a hospitalist or whatever, we have a really great role. We have a really great opportunity to role model for fellow physicians, staff, and for our patients to use non-stigmatizing language and to talk about substance use disorders as a medical problem. So there is a lot of stigma around it because there are social consequences of it, and it's considered because people are doing behaviors that are upsetting and impact relationships and the people they love, that this is, you know, maybe more of like a self-control issue. But the reality is that when you use psychoactive substances, you probably are permanently changing your brain chemistry, especially if you've developed a use disorder. And we need to acknowledge that you can't just reverse brain chemistry. We don't expect people with strokes to just like get better because they did PT for a day, you know? So when it comes to screening and brief intervention, so I think everyone's heard of like SBIRT. It's like this thing that you hear about all over the hospital. In substance use, I think it's not always done correctly, but it is evidence-based and has been shown to be helpful. So the different parts of it are to screen. So screen for substance use disorders, and we'll go over some evidence-based screening tools, sharing the information about the health impacts and of the person's substance use and the recommendations, and then assessing the readiness for change. So if they agree with you, like, hey, smoking is bad for you, you should quit. No, I'm not ready to quit. Okay, well, maybe you're not in the right stage of change for me to make the impacts I want, but how can I meet you where you are? Let's make a plan that kind of meets the patient goals. And then helping them coordinate that plan. So screening and brief intervention. The real thing is if you don't ask, you'll not know what people are doing, and you have to ask the questions correctly. So oftentimes we should be screening all the time, right? Like every physical, every pre-op exam, every admission to the hospital. We're supposed to get this good social history, and we're busy. And so we kind of cut corners sometimes, or we just check the chart and like say whatever it says. So, but the reality is if we screen, we'll find more substance use disorders. So for alcohol, you know, the CAGE questions are easy, but they're not a very sensitive test. The audit C is going to show you more people who have risky drinking behavior and are at risk for alcohol use disorder. It's just these three questions, and it has to do with how often you drink, how heavily you drink at a time, and how many episodes of heavy binge drinking or 6 or more drinks did you have in the last year. And based on these questions, you can get a really good idea based on their score if they are at risk for a substance use disorder and if you should be delving deeper. For drugs, it's called the DAST-10. This was developed in Michigan, and there's a number of questions that earn you points, and based on the number of points you get, you are at more or less risk of a substance use disorder. So, in terms of sharing the risks and harms of substance use, I think we all have that patient who's like, well, I've been smoking a pack a day since I was 12 and I'm 75 and I'm not going to quit now. And like, why are you like even talking to me about this? And it can feel really, you can get really demoralized or feel like you're not actually changing people's behavior when you tell them like they should quit smoking or that the amount of alcohol they're drinking is unsafe. But the reality is that in the data, it actually pans out that we are making a difference. So it's still worth doing, even with your patient who's been smoking since they're 12. So for patients who have unhealthy drinking behaviors, don't necessarily have an alcohol use disorder, but are, drinking the 3 or 4 beers a night or who binge every weekend, educating them on safe drinking amounts and encouraging them to cut back over time does reduce their drinking intake, which is great. And then brief intervention for tobacco, so less than 3 minutes of counseling, increases the likelihood of smoking cessation by 30%. Smoking cessation rates are low, and so 30% might not be like earth-shattering, but it's pretty impressive. So if you can increase somebody's risk of quitting by 30% in less than 3 minutes, probably worthwhile. Now, I think everyone's seen sort of the stages of change before. These really, we do want to kind of gauge where somebody is on this wheel of change when we're counseling them. Telling somebody who's pre-contemplative, not even thinking about quitting, that you want to give them Chantix is probably not going to be very effective. You really want to meet them where they are and try to push them forward. So not necessarily getting them to commit to quit today or tomorrow, but just moving them forward on those stages of change. I find this wheel a little bit discouraging because after maintenance comes relapse. I think it's trying to acknowledge that everyone is always at risk of relapse. You're never no longer at risk of relapse, but there is sort of a question of, is at some point of not using, is somebody kind of cured of their substance use disorder? And again, I like to go back to the example of somebody who's had a stroke. So if you take somebody who's had a stroke and you put them in a bunch of like PT and they go to acute rehab and they regain all their function, like it's like people almost don't even realize they ever had a stroke. It's not that that part of their brain healed, it's that their brain learned to adapt and work around the area of injury to function normally with abnormal like brain chemistry, abnormal anatomy. And so it's the same with substance use disorders. People who have a substance use disorder, they have absolutely affected their level of neurotransmitters, the number of receptors they have, the strength of the connections with their prefrontal cortex, all these things. And so when we're asking them to function in a way and act in a way that sort of is bigger than that, we're asking them to retrain their brain. And so is there a cure? That's a hot debate topic, but it looks like for people to be at lowest risk of relapse is somewhere between 3 and 5 years from their last use. So cure or normal behavior and normal thought process is probably like 5 years out for most people. All right, we're going to go into some substance-specific treatment. First, we'll talk about alcohol. So alcohol withdrawal is one of those withdrawals that can be lethal. And so we always want to be thoughtful about what setting a patient should be withdrawing in. So mild alcohol withdrawal, not so big a deal. Like you feel bad, you're anxious, you're tremulous, you like, maybe your heart's racing, you're sweaty, your stomach hurts. That's okay. When we get into moderate and severe withdrawal, we start to get more worried about this patient withdrawing in a non-monitored setting. So patients who are going to get hypertensive and tachycardic and somewhat confused, those are kind of the gray area patients where, maybe they need to go to a monitored setting for withdrawal. Maybe they can withdraw at home. It really depends on a lot of factors. people who have severe withdrawal symptoms currently or have a history of severe withdrawal, ever having a seizure, ever having DTs, ever being severely disoriented, that's an automatic. You should always withdraw in an inpatient setting. The main reason for that is because a history of severe withdrawal is an extremely strong predictor of future severe withdrawal. Alcohol withdrawal is considered to have a kindling effect, and every time a person goes through withdrawal, it tends to be a little worse than the time before. So something to keep in mind. And there's other things that we need to think about in choosing a setting for alcohol detox. Do they have a lot of other comorbidities? Do they have support people at home? If they start to have severe withdrawal, is anybody going to notice? So these are all things we take into account. There is a calculator you can use. This is in MD Calc as well, but it's called the PAUSE, or Prediction of Alcohol Withdrawal Severity Scale. I will say, so if you recall from a previous slide, 96% of people with alcohol use disorder don't think they need help. So they're not the people who are coming to me wanting to detox. It's the like 1 or 2% who recognize that they have a problem and want help. And the vast majority of those people have really severe alcohol use disorder. So I'd say probably out of like 10 patients I see in clinic, 8 to 9 out of 10 really need to be in a monitored setting. So it's really a very special patient that you can do this outpatient detox with and feel appropriate about it. This is all like built into your CWAP protocol, so you don't usually have to think about it that much. But whenever somebody is admitted to the hospital, we give them thiamine, and we use benzodiazepines as our mainstay of the CWAP protocol. And if you're detoxing someone at home, you should also give them thiamine, because their risk of Wernicke's or Korsakoff is not zero. There are other medicines used for acute alcohol withdrawal: anticonvulsants, beta blockers, alpha-adrenergic medicines like clonidine. These do not reduce your risk of alcohol withdrawal seizures. The only thing that does is benzos. So I don't know if this is across the MedStar system, but I know at my house, not my house, it's not my house, my hospital, the Depakote is now like in the CWAP protocol, and sometimes it gets accidentally clicked in things or doesn't get unclicked, but it's really not a super useful medication in the acute setting. So our mainstay is benzos. In the hospital, we often use things like lorazepam or diazepam. In the outpatient setting, we almost exclusively use long-acting benzos. So let's say you have this unicorn patient. They're perfect to do an outpatient detox, but they're not a person who's going to tolerate withdrawal, or you're like kind of on the fence about them. They might have some moderate withdrawal. Really, the best thing you can do is give them a benzo taper. So you can do Librium, which is chlordiazepoxide, or you can do clonazepam tapers. This is just one tapering option. You can find tons of protocols online. This is a 5-day taper of Librium. And they are supposed to stop drinking and start using the Librium in its place. And then at the end of their 5-day taper, they are off alcohol. Their risk of severe withdrawal or seizure should be like very minimal, and you have succeeded in getting them off alcohol. I will say the vast majority of people I've tried to do this with continue to drink and also take the Librium. So that just increases their risk of respiratory depression and also doesn't achieve the goal. So if you ever feel like you want to do this as a discharge from the ED, as a discharge from the hospital, whatever, it's good to make sure that they have a support person who can maybe administer their Librium, maybe make sure all the alcohol's out of the house before they try to do this, to increase their chances of success. Again, our anticonvulsants, not that useful. Beta blockers, alpha-adrenergic blockers, or agonists rather, agonists. They reduce adrenergic symptoms, but they don't reduce your risk of seizure. So they make people feel better, but they don't actually help with the severe withdrawal symptoms. All right, so once you have your patient off of alcohol, you won. It's time to put them on a maintenance medication. Maintenance medication is going to be way more effective than just pure willpower alone. There are 3 FDA-approved drugs for alcohol use disorder maintenance: acamprosate, naltrexone, and disulfiram. We can kind of cross disulfiram off this list. It's a garbage medication. So disulfiram, or Antabuse, it blocks acetaldehyde breakdown in the liver. So if you do drink alcohol or have alcohol intake, it causes you to have these toxic metabolites. It makes you feel like terrible, you're flushing, you're vomiting, everything is awful. The reality, though, is that if you stop taking it, you can drink. So people who have any forward thinking at all can stop taking it the day before and probably drink a little bit, unless they've been on it for a really long time and it's built up in their system. The other thing is that because it blocks metabolism in the liver, you're also going to potentially have a bunch of drug-drug interactions with a bunch of medications that your patient is on. So that's another negative. And then the last thing is alcohol is like secretly in everything. So cough syrup, tiramisu, pineapple upside down cake. Like you go to a birthday party and now you feel terrible even though you didn't drink. So people can accidentally put themselves in a disulfiram reaction like all the time. And so it has pretty low compliance. Acamprosate or Camprol has pretty good evidence. So the number needed to treat is 12 to prevent return to any drinking. And if you think about like the number needed to treat for statins, which I think is like 40 or 50 or something, you know, to prevent MI, you're actually having a pretty good number needed to treat. The downside of acamprosate is it's 2 capsules 3 times a day. And I don't know about you, but the last time I was given Keflex, I definitely missed some doses. So this medicine is effective, hard to comply with. Naltrexone is easy to comply with and has relatively good data, not quite as good as acamprosate, but you know, good enough that I think it's worth using and is the medicine I sort of gravitate to. So naltrexone comes as a pill and it comes as a once monthly injection, and it has a number to treat of 10 to reduce heavy drinking days and 25 to decrease daily drinking. It does not have statistically significant evidence for complete alcohol cessation. So that being said, it definitely helps block cravings for people. For the motivated patient, it's a great helper. The other thing with alcohol use disorder to keep in mind is that Alcoholics Anonymous and other peer support groups are very evidence-based and can meet medications in terms of efficacy. So this isn't like going to the church basement AA and sitting in the back and not talking to anybody. This is going, getting a sponsor, actively engaging. People who do that and who build a community around sobriety tend to have much higher success rates than people who do not. So if you have a patient who isn't interested in medication or is on the fence, encouraging them to just go to an AA meeting and see what it's about and, you know, feel awkward for like an hour, it's worthwhile to encourage that. There are non-FDA approved medications for alcohol use disorder. So topiramate, interestingly, it has a number needed to treat of 6 for abstinence or non-harmful drinking. So abstinence or non-harmful meaning like within the FDA guidelines for alcohol use. Number needed to treat of 6. The study was really small. It hasn't like borne out in bigger studies yet. But on the horizon, gabapentin has mixed efficacy across trials, but is sometimes used as an adjunct. Baclofen, it's like, why are we trying to use baclofen for this? The reason being is that both acamprosate and naltrexone are, if your child's PUC or for liver disease, they're contraindicated. Sometimes we weigh the pros and cons and we still use it because it's better, it's more helpful for their liver disease for them to quit drinking than we think the harm of the medication is. But baclofen's being studied because it's a little safer in our advanced liver patients. Okay. Let's move on to opiates. So for opiates, really what we need to be offering everyone who comes in wanting to stop opiates is medication-assisted treatment or medications for opiate use disorder. So those are Suboxone and methadone, or buprenorphine products, not just Suboxone and methadone. And the reason we need to be offering those to everybody is because that's going to be their greatest chance of success. People who do go through withdrawal and are not put on maintenance medications have really high risks of relapse. And because they have a period of time where they don't have opiates in their system, when they go back to opiate use, they have a high risk of overdose because they're no longer habituated to having opiates. So switching people to medication is what we should be recommending as our first line. And for many patients, buprenorphine or Suboxone is going to be a reasonable option. There are a lot of patients who feel a lot of stigma towards medications for opiate use disorder. They're like, I don't want to go to a methadone clinic. People are nodding out front. Like, it just feels like a triggering environment for me. I don't want to go. I don't want to trade one substance for another. I don't want to be dependent on anything. Well, the reality is your brain is chemically dependent, even if you don't want it to be. So really what we need to do is try to get them to the point where they want to be on those medicines. But if not, we can supervise their withdrawal and either put them on a blocker like naltrexone, or we can try to just help them with social supports. But hopefully you'll be able to counsel your patients and have them be open to our medications. So our two medications, methadone and buprenorphine. So methadone is a full agonist of the opiate receptors with a really long half-life. It binds the opiate receptors. It blocks other things from going onto the opiate receptors, like minus fentanyl. Fentanyl has really high affinity for the receptors, so it tends to mess with these medications a little more. But it binds pretty strongly to the receptors, saturates those receptors, so that if you do take another opiate on top of it, you really don't experience much like euphoria or anything from it. And it also blocks withdrawal because it's activating the receptors. Buprenorphine is a partial agonist of the opiate receptor, so it doesn't activate the receptors as strongly as your oxycodone or your fentanyl or whatever, but it does activate them enough that you're blocking withdrawal and helping with cravings. So the only issue is that buprenorphine has high affinity for the receptors, so it binds it very tightly, which is good, unless you already have opiates in your system. So for people to go on to buprenorphine, they need to actually not have taken an opiate for like 24 plus hours and be in moderate to severe withdrawal, so that when they take the buprenorphine, they don't actually just knock more opiates off the receptors and put themselves in worse withdrawal. So that can be a little challenging for people. So we have different versions of buprenorphine products. There's plain buprenorphine, which we really only use in pregnant people. There's buprenorphine with naloxone, which comes in Suboxone and Zubsolv as strips or pills. And then there's buprenorphine long-acting or Sublocade, which is a depot that's done once monthly. When you're starting somebody on this medication, you're always going to be using a dissolvable strip or a pill because we wouldn't want to go straight to an injection and then have them have a bad reaction. So in here it says for short-acting opiates, you can go 12 to 24 hours before starting your buprenorphine. Really, I encourage people to make it to 24 hours. I have a lot of people who, if they make it to 12 hours and then take buprenorphine, they go into worse withdrawal. So encouraging people to try to get past that 24-hour mark before they start buprenorphine. And fentanyl, it's good to know fentanyl, people who are using fentanyl on a regular basis, they do have deposition of active metabolites into their adipose tissue. And so you can have somebody who hasn't taken fentanyl for 24 hours, but they still have some active metabolites like leaving their fat tissues, who then will still experience withdrawal when you put them on buprenorphine. So that's another fentanyl problem. Whether you're switching somebody to buprenorphine and you're just trying to help them get through that first 24 hours, or they don't want medication and you're just trying to get them through withdrawal, this is kind of a laundry list of some of the options of things you can give them to manage their withdrawal symptoms. I don't give patients this whole pharmacy when they leave my office. What I do is I ask them what their most problematic symptoms are, and then I give them medications based on that. Most people who are using opiates know what their withdrawal feels like, because it's very rare that somebody has never experienced withdrawal when they are opiate dependent. And again, you can use naltrexone. This is a receptor blocker, but it's not really going to help with cravings, and it's certainly not going to help with withdrawal symptoms. You also have to be 7 days opiate free to start naltrexone, which is a long time to ask somebody to go without their substance before they can take this medication. For alcohol, it's only 72 hours, so usually just once they're out of that acute detox window. We're not going to talk about benzodiazepine withdrawal too much, but it's important to know that it is a potentially dangerous or fatal withdrawal, and that symptoms can wax and wane. So somebody can look like they're doing just fine, and then like a day or two later start experiencing severe withdrawal symptoms, and then they can look better. and then they can experience severe withdrawal symptoms again. So it's kind of scary to try to stop somebody abruptly off of benzos. Usually what's recommended is to try to do it in an outpatient setting. So transitioning them from Xanax or lorazepam, whatever their benzo is, to a long-acting benzo, usually clonazepam. Xanax to clonazepam is a 1-to-1. So if they're on 6 of Xanax, you can put them onto 6 of clonazepam, and then slowly tapering them down. So that's how we try to do that in the outpatient setting. In the inpatient setting, you just end up throwing meds at their symptoms and maybe using phenobarbital to reduce the risk of seizure. All right, tobacco. So this is like the quiet substance use disorder that like we don't I mean, it's super loud in that it's killing everybody, but it's we don't necessarily think of it in the same categories like alcohol use disorder or opiate use disorder, but it does have a really high morbidity and mortality rate. It is the #1 in the country. So we really need to be offering people effective treatment. So really, I think you should be offering all patients either varenicline or Chantix or buprenorphine, or not buprenorphine, bupropion. The brand name is Zyban when it's being used for tobacco cessation. These medications greatly improve people's chances of quitting. I feel like everyone is afraid of Chantix because it's going to give people vivid dreams. When they studied it, people who have the vivid dreams, for the vast majority of them, the dreams are tolerable and the benefit of the drug to them outweighs the dreams, so they continue it. The other thing is people worry about varenicline and those vivid dreams in people with mental health disorders. The studies show that in people with even severe mental health disorders, the safety and efficacy of Chantix supports using them in those populations. So Chantix has slightly better evidence than bupropion or Zyban, but both of them are effective. So I usually offer Chantix first if the patient has had a bad experience or there's some reason they don't want to use it, their cousin had a problem, then I'll offer them the bupropion or Zyban. The other thing is nicotine replacement. So patches come in 21, 14, and 7 milligrams. 21 milligrams is supposed to be a pack a day, but everyone smokes a pack of cigarettes differently. There's people who like light a cigarette and like sit talking to their sister for like the 7 minutes it takes to burn, and then they light another one, and they really haven't smoked that cigarette that much. There's other people, every cigarette they smoke, they like suck down every like milligram of nicotine out of that cigarette. So 21 milligrams equals 1 pack is not necessarily going to be a perfect thing. So really we want to do it based on symptoms. If somebody tells you they smoke a pack a day, start with a 21 milligram patch. If they're still experiencing a lot of cravings and withdrawal and they feel awful, slap another 7 milligram patch on them. You can do this in the hospital, you can do this in your clinic, but trying to get them onto a good regimen. The other thing is also it's recommended to not just use the patch, to also have breakthrough treatment. So having them have gum or lozenges that they can use on top of the patch for if they have a transient craving or, you know, cravings come out of nowhere, right? It's like, you know, somebody looked at you funny walking across the street, you get a craving. You know, you have a fight with your mom on the phone, you get a craving. So having something that you can take as needed is also really useful. You can use nicotine replacement with bupropion, and it's totally fine to use them together. Since varenicline is a nicotinic receptor partial agonist, the use of nicotine replacement with it is kind of, it probably doesn't have a huge benefit, but there's certainly no harm if the patient feels there's a benefit to them of having both. There's no medication for the withdrawal or chronic management of any other substances. For things like methamphetamine, there's some emerging things about, well, maybe since it's an amphetamine problem, we could use Adderall to treat it, but nobody's doing that on label. For cocaine, which, as I said, is a really big emerging problem, there's some studies looking at using topiramate. The data is kind of equivocal, but because we don't have good options, people are trying it. Naltrexone has also been shown to be helpful for cocaine, but not to the level of getting FDA approved for it. I think another just interesting random tidbit is that the only behavioral addiction that is considered that's in the DSM is gambling use disorder. So gambling is the only behavioral thing that's considered meeting criteria for an addiction. And they have studied naltrexone for that, and it seems to have some efficacy as well. So naltrexone seems to be like this secret helper. Okay, how am I doing on time? I'm okay, I think. Not okay? What time is it? 41? Oh, wow, I'm so fast at talking. Okay, so the last thing I want to talk about is the harm reduction model. So harm reduction is really a way of approaching patients that is patient-centered. So most people who have a substance use disorder, if somebody comes to me with a severe alcohol use disorder and they're like, and I'm say, you really need to go to a detox center, I do not recommend that you try to detox at home. That seems dangerous to me based on what you're telling me. Many people say, well, I can't go today. I can't go tomorrow. I can't go next week. I just got a new job. I don't have benefits. I have 3 kids. Like, school just started. My world is in chaos. They can't just airlift out of their life and go into detox. And same goes for opiate use disorder. A lot of people with these substance use disorders are functioning. They do have jobs. They do have families. Maybe things aren't going as smoothly as they could, but they really just can't let everything collapse around them. And so when that's the case, we really want to find ways to help them work towards their goal of coming off substances, and that's still safe, or just keep them safe until they're ready. So, when somebody comes to you for help and you start them on a medication, like we really want them to just like really engage in care, do well, and move forward. But like life is not like that for any of us. And we need to sort of respect that. So something can derail somebody's recovery at any given turn, whether it's a holiday, an anniversary of a family death, again, like a fight with their mom on the phone. It seems like there's lots of things that can sort of throw us off our path. And so just sort of recognizing we can't expect people with a messy disease to not have a messy road, and just sort of having that be an expectation. For opiate use disorder specifically, a 60% success rate at 6 months, so having negative urine drug screens at 6 months, is considered successful. And you're like, that sounds low, but let's look at our other chronic conditions. How well are we doing with those? So people with diabetes having good blood sugar control, we're around 60%. Blood pressure control, around 60%. So, holding somebody with a substance use disorder to a higher standard than we do our other chronic conditions is not fair. So recognizing that not everyone's going to be successful on their first try, not everyone's going to remain successful long-term, and it's a chronic condition that we're working on is really important. So for all of our substance use disorders, when we're trying to reduce harm for patients, we're trying to reduce their high-risk behaviors, so reduce the high-risk environments that they're putting themselves in, and then lowering transmission of communicable diseases. It's never good when somebody gets HIV or hepatitis from needle sharing, or even from snorting. You can get bloodborne things depending on what supplies you're using. And then, of course, reducing the risk of overdose and death. So for opiate use disorder, we have a few different things in our arsenal. One is naloxone or Narcan. So every time you prescribe an opiate through Cerner, it like asks you if you want to send Narcan to the pharmacy. And you probably should. I think most of us just like X out the box, and that's fine too. But Narcan is a really great tool for patients to have in their homes, for friends and family to have, to act in an overdose to reverse an opiate. You can also get people, usually from your local health department, although there are also clinics that will keep fentanyl test strips and xylazine test strips. I think the reality is if people test their substance for fentanyl or xylazine, if it tests positive, I doubt they're going to like waste their money and just throw it away, but they might be a little more mindful of what they're putting in their bodies and maybe be a little more cautious. Needle exchanges, safe injecting supplies, so providing people with safe supplies so that they can reduce their risk of getting not just Hep C and HIV, but also reduce their risk of getting abscesses and endocarditis and epidural abscesses through safe needles and safe injecting supplies, which is through certain organizations, and then also the health department, at least in Maryland, does provide those. One harm reduction strategy for opiates that is not available in Maryland, but is in some states across the country, is safe injection sites. These are kind of a hot topic because people are like, well, isn't that like enabling people if you give them this place to have to use their substance? But the reality is that safe injection sites are not just giving somebody a place and a needle. They also have peer recovery specialists, social workers on staff, people who are trying to capture those people if they decide that today's the day that I'm going to try to change my behaviors, or today's the day I want help. So it also is acting as an open door to going into treatment. For alcohol, alcohol is really baked into the culture of this country. If you watch any football game, any baseball game, there's beer everywhere. Just bars, going out drinking with friends. It's culturally normative. And so if you take somebody who has developed an alcohol use disorder, who has a friend group that doesn't have an alcohol use disorder, and you tell them, I think you need to stop using this social lubricant that you always do with your friends and never do it again in your whole entire life, that's pretty daunting. I don't think I would want to do that. So for some people, trying to just get them back into healthier drinking patterns, or trying to get them to regain some control of their drinking patterns, is something that we can try to work with them on, success being neither here nor there. The other thing is these harm reduction strategies allow patients to kind of come to their own conclusions. So me saying, I think you need help for your alcohol, and them saying, I don't think I need help for my alcohol. I say, okay, well, let's go on a journey. Let's do it your way. Let's try to get you to be healthier and safer on your terms. And then learning that isn't working for them is a great way to then say, hey, we tried it your way. You were not able to cut down to 2 beers a day from the 4 beers a day, and you still binged every weekend. Maybe you do need more help than you realize. And sort of, it gives patients time to come around to understand their own disease state. For tobacco, vaping is considered a harm reduction strategy. So vaping is it has not borne out in the data. It does not help people get off of nicotine. People just switch to vaping and they don't end up stopping. So, and actually vaping is kind of starting a lot of younger people into nicotine use, getting them hooked, and then they switch to tobacco eventually. So vaping is considered a harm reduction strategy. If the patient, if that's the only way they want to try to get off of cigarettes, fine. We can work with that, but it's not something we should be recommending as a step towards coming off of nicotine products.